Hello, hello.
I don't know for sure. Based on the conversation I had with Chief this morning, it sounds like he was.
Hey, Chief Tedesco, are you there?
Yeah, I think you're live streaming.
Yep.
Not quite yet. Are you guys ready to go?
It's going right now.
Oh, just kidding.
Okay.
Great live stream.
Yep. Little technical difficulties today, but we're getting there.
It does. I do better offsite.
Okay.
Chief
Tedesco, are you there?
You gonna hide me?
Somebody's
Yeah.
not.
I think you're live streaming.
Not quite yet. Are you guys ready to go?
One of you two guys has your YouTube not muted. Okay, so I think we're better now. Okay, it's going. Yay. All right, looks like we got about 25 people or so. So we'll give it just another minute for anybody else who wants to join. Chief Tedesco, how are you today?
Fantastic. How are you?
Wonderful. Thank you for joining. Jasmine
Quite welcome, I say.
is getting back to filming CME videos. So awesome.
It is good.
Jasmine, can you still hear me? No, she's not listening to us anymore. All right. We got a 35, so people are still hopping on. So I'm going to give it just another minute before we kick off. And in the meantime, I will get my screens ready for sharing. How's life at Clearwater today, Chief?
Very busy. Learning a lot, but very busy. I think we've seen a little bit of an uptick in calls, and certainly the severity of our patients has certainly increased as well, which I think we sort of kind of predicted in the past. So also sitting in on some really good meetings. So it's good. So far, so good.
Yeah. How are the long-term care facility visits going?
They are going. We're certainly finding our share of problems and folks maybe not doing what they should be doing, operating in the way they should be operating, but things are being reported and we're addressing things as we can.
That's good. At least we're, doing some good.
Yep. Slow, but it's going.
Yep. Okay, looks like we got about 40 watching now. So I'm just going to give it another minute or two because it's only 3:04. And we'll go get started here in just a second. I probably have some music for Peggy. Oh, not that one. Anyway, okay, so it looks like people are pretty much joining in now. So I think we'll go ahead and get started. It's 5 after, and here we go. So good afternoon, everybody. Welcome to this week's YouTube broadcast. Thank you for joining us. Chief Tedesco, thank you for joining us. And I know we're super busy, so we're going to just get right into it here and try and get as much information across as we can. So first things first, I'll share out a screen and we'll talk about numbers. All right, here's Florida today on the dashboard. Hopefully you guys can see that. Almost 42,000 cases in the state of Florida. You can see that it's still pretty variable here in the number of cases per day. Death rate also is pretty variable. It's tough to say whether we totally see a trend yet or not, but that's where we're at. We are over 900 cases in Pinellas County, 909 today, with 62 deaths. So that's important to notice that the deaths are actually increasing. We were significantly less than that at this time last week. It is also worth noting that the particular most concerning population remains our long-term care facilities. And in addition to the one that we were all aware of a couple of weeks ago, we have a few more where there are more than a case or two, and that we're working hard to try and get under control. In fact, that's my next call after this. But they are very challenging, these facilities. And I think we can talk a little bit about that here this afternoon. I did want to share one other thing here before we get into the discussion. And so that is this IHME model that some of you may have seen out of, comes from Seattle. They've updated it again yesterday or the day before. And so it still now continues to show the peak potentially ahead of us. But the sort of rate of increase or the height of the peak still remains sort of not too terribly far off from where it was. You can see somewhere around here is probably the peak as they're anticipating. But this is a fairly sort of flat progression at this point. We'll see. I think they have largely updated this based upon changes in the social distancing criteria. And so, it remains to be seen. Everybody I'm talking to from the medical standpoint believes that there's a good probability that we will see some increase in cases in the 2 to 3 week period after relaxation of some of the social distancing restrictions. And I think that is probably a reasonable anticipation. The question will be how much of an increase and whether it will get us to the point where we're really stressing the system. And according to this projection anyway, it does not appear that it will get us above thresholds for stressing the system. So that's good, at least in terms of, flattening the curve working, but obviously bad if we continue to have more people ill or unfortunately dying. So remains to be seen, but I think now that we're sort of about a week and a half from some of the relaxation, we probably have about a week and a half to go before we can say, what maybe we saw. But that's kind of where we're at. So let me get back to the other page here.
Dr. Jameson, may I ask a question based on the information that you just shared?
Please.
It has to do with the mortality rate. In some of the documents that I've been reading, it does show that mortality is a better indicator of the scale of COVID-19, and that the mortality doubling time is the most important and widely accessible metric for winning this race against COVID-19. What are your thoughts about that? And secondarily, I keep seeing several different numbers. Meaning, I don't believe we're being reported. I don't believe we're being told the real mortality rate. And I think that's really something that's kind of important for us to be looking at. And are we looking at it? I hear on the rock call different numbers as high as 65, yet we're still only reporting lower than that, if that makes sense how I'm saying that. And what's the deal? Because I think I agree with that. We should be looking at the mortality rate. It's important.
Yeah. Ongoing discussion about how to report the mortality rate. And many people are actually arguing that we're over-reporting the mortality rate. So there's a lot to this. And I'd say I don't think we totally know yet. So here's how I would unpack it for now. What I would say is, one, we know that COVID in certain people can be quite a serious disease and can cause very serious illness and or death. We also know that COVID in many people causes relatively mild disease, a bad flu, or can be asymptomatic in a large number of people. And so I think that was my phone, sorry. It's difficult to say. I had originally thought that ICU hospitalization was going to be a good metric for us to know what was truly happening, because there's some percentage of the population that gets infected, and of that there's a subset that will get no disease, a subset that will get mild disease, and a subset that will get severe disease, and then a subset of that severe disease will be the ones that actually die. So you can think of it as like a slices of the pie, or a pyramid even. And so if you wanted to know the entire population and how many people are infected, then you'd have to test everybody. Then you'd have to test them repeatedly. And we just don't have that capability. So if you want to know all the infected people, then you test everybody with symptoms, which is the basic strategy that we've been using. When I say we, I mean like the state of Florida. Or the country. And then, so if you test everybody that's symptomatic, you would know that, well, here are the infections that are symptomatic. Some subset of them are going to be the severe ones, and some subset of that are going to be the fatal ones. But you won't know the asymptomatics because you're not testing everybody. So depending on how you look at it, through what lens, I'm testing symptomatic people, I'm testing everybody, I'm testing nobody. You would get a different sort of visualization of that pyramid, or maybe iceberg is the better analogy for what you can see and can't see. And so we wish we were at a point where we could just test everybody, and test everybody maybe even repeatedly, and then we would know for sure where this virus is in the community. And I think that's sort of behind a lot of the discussion about testing as part of a reopening strategy, to really understand the virus in the community. We're getting some early information about that. And this is very early preliminary stuff, so I don't want anybody to hang their hat on it. But none of it's, peer reviewed or published yet, but this is sort of, early interpretations of what's going on. The state of Florida procured some tests, and they've been deploying them in various locations around the state. Let me flip to my notes from my call earlier today. They've tested, maybe about 1,000 people so far, and these are all like asymptomatic first responders and healthcare workers. And in various portions of the state, there were, various percent positivity rates, mostly with IgG, less with IgM. So that'd be mostly with people who are asymptomatic, but they have IgG, so they probably had an infection previously. And that number varies from, 2% up in the northern part of the state to, 9.5% down near Miami. And so overall for the state, it's something like, preliminarily 2.5% of first responders or healthcare workers might have had an exposure, whether they knew it or not, and have some protective antibodies to the virus. Now, these are very early numbers, and there's a lot of selection bias in who's getting tested at this point. So I would fully expect those numbers to change largely before they are considered an accurate number. And I'll tell you, at a hospital I know about, they were offering IgG testing to staff, just anybody who wants it can get it. And, they had an initial, and again, very early on, very initial, expected to change, but their numbers were like less than 1%. So, that paints a different picture. If 10% of your people have some immunity potentially, or 1% or less have some immunity potentially, it's a slightly different picture. I think the discussion previously about IgG and whether or not it confers immunity, I think the evidence is now pointing to that it does, and that those reports of reinfection were likely more reactivation or shedding of viral debris rather than active virus that was being picked up in the PCR test. But it does seem like the data is pointing more and more towards IgG offering some protective function. The question remains how long that lasts, though. So it's not like, chickenpox party time. So we don't know for sure on that yet. But, the testing strategy is evolving and moving, and we've actually ordered an initial batch of 2,000 tests, and have submitted an IRB, and have partnered with the lab over at TGH to validate those point of care tests. And we're going to be looking for some volunteers to be our validation sample here pretty soon. And after that, we will likely look to try and test everybody with a point of care finger stick IgG IgM test as soon as we're able. It's probably be a couple weeks yet, but we would anticipate doing that one, and then probably doing some follow-up testing and maybe expanding to include law enforcement, et cetera, further on as we get into the summer. So that's where we're at with the testing, and the mortality rate is some sort of a subset of a subset. And the other issue with the mortality rate is that if you have COVID and you get hit by a bus, was it a COVID death or a traumatic death? If you have COVID and you get shot, what's the cause of death? So I think one thing that's sort of subtle and maybe people aren't familiar with unless they've ever filled out a death certificate is that cause of death can be slightly complicated. So, we used to joke about the cause of every single death is cardiopulmonary arrest. But is that really the cause of death, or is that just the proximate event that, you died? So, filling out death certificates, sometimes you might write, here's an example. So primary cause of death is cardiopulmonary arrest. Secondary cause of death is STEMI. Tertiary cause of death or contributing factors include hyperlipidemia, hypertension, diabetes. Do you see what I'm getting at? So it can be a little bit more complicated than just it was a COVID death or it was not a COVID death. And some people think that it's being overreported, whether it was truly attributable to COVID or not. And other people think it's being underreported, whether it was truly attributable to COVID or not. And, the trauma is one example, but what if you have a heart attack and you happen to have COVID? Well, we're learning that COVID, and we're seeing this in both kids and adults, COVID is causing a significantly hyperinflammatory and hypercoagulable state, which could trigger a heart attack. But what if you already had underlying atherosclerotic disease? Is it still a COVID death, or is it a cardiovascular disease death that happened to be precipitated by the fact that you had COVID? So anyway, it's just by way of saying it's a little bit more complicated than maybe it's being made out to be in the media. And so I think you just need to be careful about interpreting how the numbers are reported. And I would argue that we should probably report the numbers in ways similar to how we've previously reported numbers, and not alter what is generally agreed upon as to how we classify these deaths for the sake of consistency. But I think there are certainly, depending on your role or your affiliation or whatever else, there may be motivational factors or incentives to report things one way or another, depending on what you're interested in looking at. So I guess I would just caution, I do not believe there is any conspiracy in terms of relating the deaths. I do believe that there are sort of different interpretations and different ideas about how things should be classified. And that's definitely a very valid discussion point, but not something where I think we need to be, thinking there's some big conspiracy theory. What else? Other questions, Chief? We don't have a lot. We've got 66 people on the stream. No big comments yet. So I wanted to cover a couple other things. You were on it with me today on the Eagles webinar and the Florida discussion. So there was a couple of interesting topics that came up. If I just look at my notes, I think I've mentioned Dr. Osterholm in the past on these YouTubes. He's the guy out of University of Minnesota, the CIDRAP organization. And he joined us on the webinar today and gave a little update in terms of his predictions and interpretations of what's happening. And he had a few interesting things to say. So this is the guy that I referred to previously, talking about we're in the second inning of this. And I think he still sort of feels that way. He is actually getting ready to release a new report over the next day or two, which may be worth looking at. You can find it on the CIDRAP, that's CIDRAP website. Just Google that. So I'm looking forward to reading what his next updates are in relation to predicting how this is going to go. He is he's been pretty spot on with most of his predictions, so we'll see. An interesting thing is that the performance of various testing methodologies is still evolving, and comparing the finger stick versus the PCR, the different methodologies, what it tells you, and the accuracy of those is quite difficult and fraught with some potential challenges. So be aware that, you know, even the nasal PCR, that's the nucleic acid amplification test, which is basically looking for viral RNA in your nose or in your spit now, you know, isn't 100% perfect. You may be positive even after you've recovered from the virus because you're still having viral debris shedding, and you may now being reported a 7 or 8% false negative rate on some of these tests, which is, you know, not super comforting. So the testing and understanding the distribution of the disease remains a big challenge for us right now. Let's see if there's anything else I wrote down that should be really shared. We did have a report from docs around the country as to what they're seeing from EMS docs around the country. Glenn Aceda, my old boss up in New York, is saying that they're actually getting back to normal and even had some low EMS volume in the city. And their cardiac arrest rate is getting back to near normal, even though it was like 8 times normal there for a few weeks. So things seem to be kind of settling down up there, but they're still obviously taking care of a lot of patients up there. There was an interesting discussion of a Italian study. Dr. Amal Mattu was on the webinar with us today as well. And he is a guy that you probably heard me talk about before. He's a cardiologist. Well, he's actually an ER guy, but his sort of area of expertise is cardiology. He's a guy who put out lots of videos on YouTube and, you know, EKG of the week kind of stuff, teaches classes for, you know, ER doctors on EKG interpretation. He's kind of like our guru on all things cardiology within the ER community. And he was pointing out a study that just got sent out there from Italy, where they did a case series of patients with STEMI who also had COVID. And it's a relatively small case series, but not tiny. It's 27 cases. And these are patients that were in the hospital with a STEMI who also tested positive for COVID. And 24 of the 27 patients, if I heard him correctly, 24 of the 27 patients, they had no viral infection like symptoms at presentation. Their presentation was a STEMI, and they were COVID positive. And the thought process is that it's the inflammation from COVID that actually precipitated the STEMI, but they had no cough, no fever, no, you know, nasal or GI or anything else. Their presentation was actually the STEMI. And that's sort of jaw-dropping and very concerning that 85% of these STEMIs had no viral symptoms whatsoever. They were just came in with their ST elevation and their STEMI symptoms. So super concerning and continues to show how this virus is just a chameleon and looks different ways. This may have some correlation to the previous discussion about the Kawasaki-like presentation that we're seeing in some kids. So I think we talked about this last time, but if we didn't, Kawasaki's disease is an inflammatory disease in children. And the mnemonic you learn in med school is Kawasaki kills kids' coronaries. And so it results in coronary artery damage in children And this is actually the reason for those of you who have kids, that if your kid had a fever for 5 or more days, they tell you to go see the doctor because you need to get ruled out for Kawasaki disease, because you shouldn't have a fever that lasts that long without an obvious source. There's definitely something going on with this virus, and a hyperinflammatory, hypercoagulable kind of state. The numbers on people with PEs, despite anticoagulation with this virus, are very high. That continues to evolve. So this is one of those ones where it's like, it's not just a regular flu-like. There's a lot of other presentations of this disease, which again probably also contributes to the confusion surrounding cause of death and what's a death attributable to the virus versus other things. Other interesting, oops. Sorry. One second. I better. Sorry. I'll get in trouble if I don't answer the phone when it's my wife. There are some other things that we probably need to get ready for. A lot of people are talking about the second wave and what's that going to look like. A lot of people are talking about, how are we going to get a mass vaccination campaign done when and if we do get a vaccine. So there's a lot of moving parts to this, and just because we seem to be over the initial sort of wave or hump, if you want to, but however you want to say it, now we have to get into a mode where it's what's next. And along with that, we also have to get into a mode of how do we learn to do good care while staying safe and wearing our PPE. And so we started this discussion last time, and we had asked for somebody to volunteer to put together a template that we could use for people who are hard of hearing or for whom discussions or gathering a clinical history is difficult. And so we did get that template. And so thank you to Chris who did that. And what I've done here is I had Dr. Smith add his suggestions. And what I'd like to do now is actually share this on the screen and have you guys help give your input to it. I guess before we do that, it's probably good if I just stop for a second and take any questions on all of the stuff that we just covered there, because we talked about a bunch. So any questions from the group about the epidemiology, what we can expect, the clinical presentation of COVID? They're quiet today, Chief. There's 75 people on it. Nobody wants to talk. All right, we'll give them a minute because I think there's a delay. Any other things that you've been working on or wanted to talk about while we wait, Chief?
No. So one of the things also, if you want to talk a little bit about it, that Dr. Osterholm emphasized, and so did Dr. Ju, was the concept that how aerosolized this COVID is, and that concept is being underplayed by a lot of folks, it seems, but that what Dr. Osterholm has been saying for the longest time is this is an airborne disease and that can't be taken lightly. Do you have any thoughts about that? Because I found that really to be very interesting, the way both of them talked about that and how, again, people are undermining that and underplaying that.
Yeah, that was an interesting analogy he gave too, right? The idea is that, respiratory precautions is essentially droplet, right? So that's like a big cough or a sneeze kind of thing, which is very different from aerosolized virus, which you would get in a medical setting or with a virus that can go on an aerosol particle. And the analogy he gave is, if you're standing at an intersection and there's a Mack truck coming at you, and you're wearing a no mask, it'll hit you. But if you're wearing a surgical mask instead of an N95 mask, okay, well, maybe only a pickup truck worth of the virus hits you, but it's still going to hurt you either way. And it's interesting that what he was trying to highlight is the places where people were wearing surgical masks instead of N95 masks or better, the infection rate seems to be higher among healthcare providers. So in a lot of places, they said a surgical mask is adequate unless you're doing aerosolizing procedures. And the answer to that is, I'm not so sure. And that is why I have been pushing us to be N95 or better the whole time. And I think the data is bearing that out. It is worth mentioning that the purpose of the mask on the patient is to protect us. The purpose of the mask on the patient has nothing to do with the patient. It's all about protecting us. So if we can knock down from a Mack truck coming at us to an F-150 coming at us, we've got a lot better chance of our N95 or P100 stopping it. Now, our N95 or P100 should stop it no matter what. But, what if you sneeze and you lose a seal for a second? I'd like to minimize the number of particles that are coming at me. And while there's no way the surgical mask or the procedure mask is going to stop an aerosolized or an airborne particle, it is going to knock down some of the larger particles and at least, maybe reduce the overall number of virus particles coming in your face, which, I'll take any reduction I can get. So that's the whole point of the surgical mask on the patient. It's really about protecting us, not protecting the patient. There is still debate about, the effectiveness of wearing masks outside of work or even in the fire station, as some folks are doing. I think that's open for debate. I think some of the experts say, yeah, of course, why not? And some of the experts say, well, it may not get you as much as we'd like, and you shouldn't use that as a substitute for social distancing. I don't know the answer to that. I don't think anybody knows the answer to that yet. But why not? Why not? If there's something I can do to reduce it, then let's do that, because we are getting to a point now where, it's not just about protecting you from the infection, but it's about protecting you, who might be a healthy person and has an asymptomatic infection completely. You have no idea you have it, but you could then, transmit that to a family member or somebody at Publix or whatever it is. So, the more you can do with mask wearing, it's probably a good thing. I mean, I'm still wearing a mask anytime I'm in a non-socially distanced kind of a place. And I try to avoid those places as much as possible. I'm still wearing a mask. I'm still wearing an N95 or P100 let me put it this way. I'm wearing an N95 for every single patient contact I have at this point. So I actually wear an N95 my entire shift in the ER. And I switch over to a P100 if I'm going to be doing an aerosolized generating procedure. I put a full face respirator on because I want better protection for my eyes is all, really. Usually I can get away without my glasses, but that's kind of where I'm at. I did that partly because I wanted to make sure I was able to appreciate what it's like to do the care in the P100 masks. And it's not easy, I'll give you that. But, if I can protect all my, eye mucosa, nose mucosa, and mouth from potential virus, that seems like a pretty good idea. So that's where I'm at. And I get it. I know my nose is like bruised and hurting, but from the N95 mask by the end of 8 or 10 or 12 hours, it's not fun. Makes it hard to communicate, all that stuff. But, better that than I get an asymptomatic infection and give it to my 80-year-old dad. All right. Anything else from the webinar that you were on today, Chief? I think there was a lot of good stuff.
There was a lot of information from all of the physicians. It's good to hear the report around, what's going on around the world as well. One other thing I wanted to ask you about, if I may, that Dr. Osterholm did talk about, and that was the fact that the cases that he's thinking will decrease through the summer, but then pick up again in the fall. And he was talking about some of the past pandemics that we've had, and what relation that's going to have to COVID-19. What are your thoughts about that? Because we're coming into a little bit of a lull, and to that end, maybe as a community, everyone out there, what can we do during this lull that we're seemingly experiencing to prepare ourselves moving into that future, should the fall do what Dr. Osterholm was predicting it's going to do?
Yeah, that's a big concern, is that, are we going to be right back where we are, a few weeks ago in September? And I sure hope not, because I'd love to go to a football game, but it's possible. And that is something that I think I mentioned before on the YouTube, that historically, in previous pandemics that we've seen in the last 100 years, almost invariably there's been a second wave, and generally that comes in the next as the season turns cooler again. I don't know if it's going to happen. I hope not. I hope that people stay smart. I hope that we move quickly on a vaccine. I have very little faith that we'll have a vaccine by September, at least not one that's ready for widespread use. Lots of people are working on it, but I wouldn't want to hold my breath for that one quite yet. I don't know. I think it's a good chance, and I think that's one of the reasons why we've really got to learn to live and work with COVID, and to still be able to provide good care and keep ourselves and our patients safe. Because I don't think that we're going to be done with this, by July 4th. I just don't think that's right. I don't think we'll be done with it by Labor Day. So that's kind of doom and gloom, but I think it's probably accurate and backed up by historical kind of precedent. There's a question here from Test123. That's a very creative username. It is, with the increase in trauma call and with this virus causing some clotting issues, is there a worry about long-term health problems such as strokes or bleeds? Yeah, absolutely. So you heard me mention a minute ago about the STEMIs related to the hypercoagulable or hyperinflammatory state. It's like two slightly different things, hypercoagulable and hyperinflammatory, but they sort of go hand in hand. But yes, there's been a lot of discussion about PEs, strokes, STEMIs, all of those type issues, and that COVID may be presenting as those, or having that as part of the presentation of COVID. So aside from getting sick, getting pneumonia, going into respiratory failure / multi-organ system failure / ARDS and dying, there's a lot of other impacts of this virus, whether that is a heart attack, a stroke, a PE, whether that's a Kawasaki-like vasculitis in a child, or whether that's, I didn't get my chemo for the last 6 months because everything was closed, or whether that's I, got hit by a car because I was walking instead of taking public transportation. The total impact of this virus on the health of our population is way bigger than just the pneumonia, ARDS kind of a thing. And it is worth keeping that in mind, that this is a much more global impact to both the health of society as well as society as a whole than just that pneumonia-like picture. Again, something we're going to have to learn to kind of deal with and mitigate on an ongoing basis, I think. All right. With that, let's go into the draft worksheet and see if we can get some people to speak up here and help us make any improvements to it. So here it is. And again, we were gonna allow, like a picture of the individual person without a mask on here, so that you can kind of show your patient who you are, because communication without that mask, establishing the rapport without that mask, may be kind of important. So here it is. Let me know what you guys think. One thing I noticed so far that I thought was maybe the pain scale should be the visual pain scale with the smiley face and the happy face as opposed to all that word. And then I thought maybe the text could be bigger. The idea was to leave the back side of it for writing individualized questions with a marker. So I'll give you guys a minute to look at this. And hopefully you guys will throw up in the comments whether you think this looks good, whether you think it should be changed, any suggestions. Nothing yet. What do you think, Chief?
So I just emailed you what I received from a little experiment that some crews are doing, which seems pretty decent. And one of the things they're doing is while they're attempting to make eye contact, one of the clinicians will ask, "Can you see my eyes?" Then after eye contact is made, smile and ask, "Even though you can't see my mouth, can you tell me that I'm smiling?" Do you feel that might not be bad? Do you feel that it might be something that we could add on to this? And what does the group think about that? A lot can be conveyed in the eyes, through the eyes, which is, no doubt. So what are some of your thoughts out there? And Dr. Jameson, what are your thoughts? Thanks to Lieutenant Main, who did put this together. So we appreciate that. These are just some ideas that came through the last call or the last Q&A session or two, just to help better our communication skills. And again, to bring humanity back into our paramedic skills and our paramedic and EMT interactions.
Okay, so the first question from Dan is there going to be Spanish versions as well as other more popular languages? Yeah, I think absolutely. We were making Spanish versions of stuff, and I think we were making Vietnamese versions and possibly some other ones, but we certainly can do that. But before we even get to that, what do you guys think of this actual format, or what the questions are and all that kind of stuff? The eye expression thing is really an amazing concept. Tony, who came up with that?
I have to give credit to Ed Wilson and crew, who he is working with some of his crews to do this on a little mini study. So kudos to them. I think it's a great idea. Also, Jacob put there that maybe we should number the questions so that they can flip it over for more room to answer. And I think that's a really good idea as well. So well done, Jacob, for sure. And then did you see Scott Zweifel? An idea if patients will need to disclose they are COVID positive to healthcare workers, first responders, or any changes in HIPAA during this pandemic.
Sure. So the larger typeset that Dan said, yeah, absolutely, making sure that it's spaced out big enough. And Jacob as well, flip it over. Yeah, the idea was to leave the back blank to write questions that you need specific to the patient's complaint. But we could certainly try and space out and make bigger as best as possible, or make two sheets if we need. I don't know, one with all the questions and one that's blank.
And certainly number the questions as well.
Number the questions, okay.
I think that's a good idea.
Done.
Easy, right? Absolutely.
So Zweifel's question about disclose if they are COVID positive to healthcare workers, first responders, or any changes to HIPAA during this pandemic. I have not seen anything other than HIPAA remains in force. There have been some guidance that it's okay to share status of patients with other healthcare providers that are caring for that patient, just to make sure that we're all doing the same thing. But in general, there's no exception to HIPAA or anything else like that at this point. Patients continue to have their right to privacy. There's always been, for communicable diseases, if somebody is actively infected, like tuberculosis, you probably want to share that information with the next healthcare provider to keep them safe. But no, I don't think there's going to be any change to HIPAA, and I have not seen anybody talking about a mandatory disclosure. I mean, they don't have that.
Yeah, sorry about that. I thought that question was initially referring to putting that question on the sheet, on the form. Are you positive? Are you COVID positive? Have you been diagnosed? Something along those lines relative to COVID. So my apologies. I didn't read that close enough. So sorry about that.
If that's what you were actually meaning by that question, because that's actually an interesting idea as being one of the questions.
And then I was texted another suggestion that had to do with putting verbiage for acceptance signature for clinicians who transport on the back.
What do you mean? Do you mean the verbiage off the EPCR for the signature?
Well, I'll find out momentarily. Hold on that.
So Scott says both on this. Okay, yeah. So Scott, I'm going to put that on there and figure out how we can make that appropriate on there. Shane says, any chance of adding some type of question on a little more personal level to get a better rapport?
Like what?
Like what? Yeah. So make a suggestion. Who the heck? All right. Some people had wanted to have like an OPQRST or sample mnemonic on there, but that seemed like a lot to fit into this thing. And that's really like a memory aid for us rather than a direct question to the patient. You can't just like put sample in front of the patient and expect them to fill it in, I don't think.
In answer to the other question, as far as the acceptance signature, it has to do with, ma'am, do I have your permission to sign the tablet on your behalf? ... Things like that.
Okay. Anything else? They're being
Anything else?
being very shy today. Like 3 people have chimed in.
Well, if anyone wants to see this form changed, now's your chance. Instead of complaining about it later on.
But that's the more fun way to do it. All right. So please, favorite sports team, what I do in my free time, why I begin. Oh, you're talking about information about you, Shane. I thought you were talking about like personal questions for the patient. That's very funny, Chief James. All right, like that, Shane. Ooh, emergency contact info. That's a good one. Sure. While I'm waiting for more suggestions, emergency contact stuff was great. Zweifel, thank you. Chief Magnus, yeah, we did cover it, but basically we've ordered 2,000 finger sticks, and we're going to validate them in a small group, probably about 30 asymptomatic first responders. We'll take 2 samples, 1 finger stick, 1 venous. We'll run the finger stick on the point of care test. We'll run the venous in the lab at TGH, and we'll see how well they match. And then we'll also run a handful of known positive cases from the hospital on the finger sticks and see how they do. And if that all looks good, then we'll roll it out system-wide as the initial plan probably. And then following that, we would maybe be able to also include law enforcement and repeat testing going forward. So still a little bit of the ways out. We've submitted the IRB, we've purchased the tests. So as long as all those pieces come together, we have a plan. The state is using the CellX tests that they got, but those are all blood draw, not finger stick yet. So we'll see if they can get them authorized for finger stick. But they're not currently. All right, Hudak says that looks good. Okay, so you can put like your favorite sports team emblem over your picture. Okay, any other suggestions on this form? Otherwise, we'll take it back in the lab and cook something up and hopefully be able to distribute it pretty soon. I think you would have to, Chief, right, you would have to, as the agency, pop your own logo and own image of the person in here. So we just send the template and then you could fill it in and laminate it. Right. Hudak says that looks good. Okay. So you can put like your favorite sports team emblem over your picture. Your YouTube.
This is killing me.
Okay. So
In answer to your question, yes.
Awesome. Okay, so that'll be our tentative plan. So the other thing I wanted us to cover, it's already 3:50, so I don't want to go too long today, but I wanted Jasmine to talk briefly about the discussion from last week and from EMS training group about a little revision to.
Stay here.
It's still being discussed and being worked through, but just for sharing what we're thinking about with the group and with what's discussed at LG, and overview of what we're considering.
All right. So you're echoing really bad, so I can't really answer your questions. Are you ready for me?
Yeah, go ahead.
Okay. So a quick update on CME. We are going to be releasing 2 CMEs at the beginning of June. The first one is going to be the Pediatric Patient Assessment Part 2. And then the next piece is going to be related to PPE, as we've been discussing here. We're going to go over some ways to communicate and effectively do patient assessment in full PPE. So those 2 things are going to be coming out in the beginning of June. Also, your April CME will be, the 60-day timer will be up on that at the end of the month, this month.
Those are still tentative, or still need to go through LG and all that process, or that's the final plan?
For the CMEs, we're going to go through the training plan again. That's really going to cover dates and changes, but we are working on recording those videos now. So hopefully that is the plan.
Okay, moving fast. I love it. All right, any other updates or reminders for the group while we have them on? You said there's a deadline coming up on a CME or something?
April CME was on a 60-day timer rather than the normal 30. So that will be up at the end of this month. That is the Pediatric Patient Assessment Part 1.
Yes, cool. So please get that done. We've got a great group in orientation this week. We've got a bunch of medics, a bunch of EMTs, and a critical care nurse, I believe. And both last Monday and this Monday were a really nice group. So I appreciated them and enjoyed spending the day with them. Excited for them to be in our system. I think there's some really good clinicians in there. All right, let's see. We got any other comments? Okay, last chance, everybody. Go ahead and throw in any other questions you have or any other issues you'd like us to talk about. And then we will call it a day. If not, we are planning on Tuesdays now for this, right? So next Tuesday, a week from today would be the next one. Oh, you know what I have a question is, who else would you guys like to hear from? I've invited, hopefully I can get Dr. Cho from the health department to come on with us next Tuesday. If you guys wanted to hear from, I don't know, other docs like infectious disease people or other EMS docs or the state medical director or whoever else, just let me know and I'll try and get them on. Dr. Antevi is always super fun to hang out with. So if you guys want me to try and get him on, we can do that. But drop something in the comments or pop me an email or a text if there's somebody you want to hear from their perspective on all this stuff.
I think maybe Dr. Osterholm, if you can manage that one, that'd be kind of cool. Or even maybe Dr. Pepe, that'd be kind of cool. Or maybe ACA and how they inspect facilities and things along those lines and give us an idea of what they do or don't.
Yeah, so I could certainly try for Dr. Osterholm. I think his schedule is pretty damn booked for a while. He said today that he was running from 7 a.m. to 8:30 p.m. with no breaks. So I can certainly try and see if Dr. Pepe would like to join us as well. All right, I don't see any other comments. They are a very quiet group today, Jasmine. Really, like.
It's because I wasn't here.
Oh, well, you're here now, so they should start talking. Literally, like 5 people talked. That was it.
Oh, no.
Yeah. Where's Peggy when you need her?
All right. Well, we'll be doing this again next Tuesday at 3 o'clock.
Okay, so next Tuesday, 3 p.m. And please, any thoughts you have after the fact on that communication form, any suggestions you have for upcoming topics, visitors on the YouTube or training issues, please pass them along. I'll just tease that before too long, we are going to have to get into our protocol update regime. And we do have a couple of potential things we're considering, like pediatric king tubes, like push dose epi, and the every year discussion about ketamine. And we'll go from there. So Shane is asking for a peds doc. All right, I'll ask Dr. Antevi if he wants to try and join us maybe next week or the week after. Cool. Okay, please do not let up on the PPE. Stay safe. This is still out there. There are still active cases, even though it seems like a lot at the nursing homes. The staff at those nursing homes shop at the same Publix as you. And please, please, please keep staying safe. It's just so amazing how well you guys have done on this. But I have heard a couple of instances where people weren't necessarily wearing their PPE like they should. And so please do not get complacent on this. It is a pain in the butt. I get it, but you know, it's not worth getting it. Please keep yourself safe and we'll see you next time.
Stay safe out there.
See you, everyone. You there?